going to discuss glaucoma treatments, and then toward the end of the talk I'm going to discuss a surgery that, although relatively new, has been the goal of surgeons for at least 50 years to achieve. So first of all, before getting into glaucoma, its treatments, let's just talk for a moment about the anatomy of the eye. So most of you have seen the front of the eye. You may not actually be familiar with all of the terms, the anatomy. The clear part that we put contact lenses on, that's the cornea. That focuses light through the iris, through the pupil, which is the center of the iris, this muscle here, through the lens. Now it's the lens that eventually becomes a cataract. The lens then focuses light onto the retina. The retina collects that light, sends a signal back through the optic nerve. The optic nerve is best thought of as the cable from the eye to the brain. Glaucoma is a disease essentially of this cable. All right, so that is better. So the best way to think about the eye is a bit like a video camera hooked up to your TV or a computer. And so light, just as it enters the eye back to the retina, in a video camera it would enter through the lens, through the aperture, and then it would hit what's called the CCD, charge coupling device in a video camera. That then converts that light into an electrical signal and sends it through a cable to your TV or computer. Well, just like a video camera and a computer, if you've got a gnawed-up cable, the cat's been chewing on it, it doesn't matter whether you've got the world's best video camera and the best computer. That $5 cable is going to make all the difference in the quality of the image. And the same is true of the eye. You could have an absolutely perfectly clear cornea and lens, beautiful retina with no macular degeneration or other condition, but if your optic nerve is damaged, it doesn't matter how good the eye is, and it doesn't matter how healthy your brain is. You're not going to get good vision. So this here, this little nerve, about 1.5 millimeters in diameter, is what takes the signal from the eye to the brain. This is what a healthy optic nerve looks like. If you're looking down on it, from the front of the eye, down, this cross section here, and what you see is that you've got good healthy tissue here, the blood vessels are going back through the nerve. This is what a glaucomatous optic nerve looks like. Okay? So essentially, this is what we call cupping. What's happened is all these nerve fibers that go back through this tube have died off. And when they die off, you get this empty space, this cup. So this is what we're talking about when we're talking about optic nerve cupping in glaucoma. So let's actually take a look at glaucoma. All right, so what happens is fluid is produced in what's called the ciliary body, and it goes around the iris and then exits out through what's called the trabecular meshwork. If the fluid can't get out, it causes pressure to go up in the eye, damaging the optic nerve. Now, generally, glaucoma is something that does not impact your central vision right away, but over time, it can actually decrease your peripheral vision, and only in the end stages do you lose central vision. And so this is what's so awful about glaucoma, is since you're not losing central vision right away, you don't necessarily notice it. Glaucoma is pretty common. 2.7 million people in the United States have glaucoma. But here's what's scary. 50% of them don't even know that they have it. This is why glaucoma is called the silent thief of sight. Okay. This slide was intentionally left blank to remind us that glaucoma blinds. And unlike cataract surgery and other conditions of the eye, it's permanent. it's forever. You lose vision from glaucoma, it's gone. This is why it's so important to detect it and detect it early. So, in terms of detecting it, we've learned through many studies trying to detect not just glaucoma, but other diseases such as prostate cancer, breast cancer, that you don't just want to test everybody, because you're going to actually end up catching people and thinking that they have glaucoma when they don't. So you need to test those who are at high risk. Well, who's at risk? Well, glaucoma is common in 2 points in our life. When we're infants, and then pretty much we don't see glaucoma through most of our young adulthood. But then as we start to get older, 40, 50, 60, the incidence of glaucoma increases with every decade of age. So as we get older, it's important to actually get tested for glaucoma. Certain races are more common, or more likely to have glaucoma. Those of African descent, those of Latino descent, certain Northern Europeans. So I mean, really, it's pretty common in many races. And then actually quite common, the narrow angle type in many Asian cultures. Family history. If you have a family member with glaucoma, you are more likely to get glaucoma. Now, if you don't have any family members, that doesn't get you off. Okay? But if you do, you really should be tested. You should be screened. And then medical history. Glaucoma is more common in those who have conditions such as sleep apnea, diabetes, number of different conditions, including common ones such as high blood pressure. So how do we detect glaucoma? Well, the intraocular pressure is a quick and easy way of screening. And generally, if the pressure is high, above 22, we need to consider the possibility of glaucoma. But we now know that glaucoma can occur in those with normal pressures. So just because your pressure is less, 22 or less, does not mean that you don't have glaucoma. And indeed, we now know that in certain races, Asian races, especially the Japanese, low pressure or normal tension glaucoma is quite common. So what do we do then if the pressure is not going to give us enough information? Well, visual fields. I showed you earlier that glaucoma decreases the peripheral vision first. So what can be done about that? We can actually test your visual fields. This is not something that you can do on your own, because just as we don't generally think about the fact that we can't see something behind our head, you're not going to notice if your visual field slowly comes in until you start bumping into doorways. Well, that's a bit on the late side. Optic nerve exams. A clinical exam with an ophthalmologist looking at what's called a slit lamp or biomicroscope with special lenses can give a magnified view and allow the ophthalmologist to actually assess the health of the optic nerve. But we now have wonderful technology called SDOCT, which essentially gives us a microscopic view of the layers in the eye, including the optic nerve. And that's this. So once glaucoma has been diagnosed, how is it treated? Well, traditionally it's treated with eye drops. And I'm not going to spend a lot of time on the eye drops today because I really wanted to focus on the surgeries, what's newer in glaucoma, and there's not much that's really been new about the eye drops for the last 10 or 15 years. The eye drops work well for most people. The older ones are quite inexpensive. They can be as inexpensive as $5, $10 a bottle. The newer ones, unfortunately, that are still branded, can be anywhere from $80 to $150 a bottle. So cost can be prohibitive with eye drops. Additionally, the eye drops, like all medications, even though you're just taking it in the eye, these eye drops can go back into the nose, be absorbed into the bloodstream through the sinuses, and it is possible to actually have systemic symptoms. One of the oldest eye drops around, beta blocker, timolol, generally safe in young, healthy people. I had a patient of mine in his 40s, athletic. He took his first drop of timolol, ended up in the emergency room because his heart rate had dropped, along with the blood pressure. So these drops are not without side effects, but they can work very well. So what do you do if you can't tolerate or you can't afford the eye drops or they're not working? Well, the next treatment is generally a laser treatment. And in Europe, they actually go straight to the laser before the eye drops. If the lasers don't work, there are surgical treatments, and we'll talk about those in more detail. So the laser surgeries, let's go over those quickly. As I mentioned briefly earlier in the talk, we believe that the restriction to flow, so remember the fluid is produced in the eye, here at the ciliary body, that fluid bathes all the structures in the eye, keeps everything healthy, takes out the garbage, and goes out through this little drainage canal called the trabecular meshwork. Well, that seems to get clogged up. So just like your sink at home, it gets clogged up. So what do? Well, there's a couple of lasers, argon laser trabeculoplasty, selective laser trabeculoplasty, that are low-risk laser procedures that have been used for many years. And through some mechanism that, frankly, we just don't understand, it seems to open up the system. And you get about as much effect as you would from an eye drop. Very low risk. Occasionally, as with any glaucoma surgery, you can actually end up with a paradoxical spike in pressure after the surgery. But it's rare and unusual with the selective laser trabeculoplasty, which is available here at San Gabriel. So any doctor, any ophthalmologist who's on staff at San Gabriel has access to that laser. Okay. Now, that sounds great, but what if you need more pressure lowering than the laser or a drop can provide? Or what if, as happens with selective laser trabeculoplasty, it wears off after time? And these laser treatments do wear off in about 3 to 6 years. Well, then we need to consider surgical treatment. The traditional surgical treatment is called trabeculectomy. Now, the interesting thing about trabeculectomy is that trabeculectomy was first described in 1968 by Dr. Carnes. And what Dr. Carnes was trying to do back in 1968 was essentially open up a window to the natural drainage canal called Schlemm's Canal. Okay? He did that by removing part of that trabecular meshwork, so that drainage grate. And the goal was essentially to get fluid to go through this grate, around the canal, and out through the natural drainage canal, the drainage system. Okay. But what happened is that most everybody that had the surgery in 1968, whose pressure lowered, actually ended up with what's called a bleb. So the fluid, instead of going out the natural drainage system, went through here and created a blister underneath the clear part of the eye called the conjunctiva. Well, that, to Dr. Carnes, was a complete failure. He was trying to avoid fluid leaving the eye through an non-physiologic process. He wanted to reestablish the natural flow. But the crazy thing is that even though these were considered to be failures, it worked better than everything else that was available at the time. And so trabeculectomy, a failed attempt to do what's called a non-penetrating surgery, became the gold standard. And to this day, trabeculectomy is considered to be the gold standard of glaucoma surgery. Yet, it's invasive. We have to actually create a hole in the eye. You can have problems with severe bleeding. These blebs, these blisters, they tend not to last because, well, the body wants to get rid of a blister. It tries to scar it down. Now, we can keep it from scarring down by using what's called an anti-metabolite, which is essentially a toxin that kills the tissue that tries to repair this bleb or the wound. Well, what happens if you destroy tissue that's there to repair? You end up with a lifetime risk of infection in the eye that's had the bleb. And then because these blisters are so delicate, right, you have to limit your lifestyle. If you like to do things outdoors that involve dirt or water sports or things where you could accidentally get your eye hit or minor trauma, this becomes an issue for you. So ironically, the most commonly performed glaucoma surgery in the world is actually something that was a failed attempt at doing something else, but it just works better than anything else at lowering the pressure. Now, here's the thing that concerns most patients, concerns me, and most ophthalmologists. Glaucoma is a disease of slowly progressive loss of vision. We are trying to prevent further loss of vision. Okay. So, taking a risk of creating a loss of vision is something that has to be considered very, very seriously. What is the risk of surgery versus the risk of not doing surgery? So generally, we do not recommend trabeculectomy until significant loss of vision has already occurred, and we see that it's progressing fast enough that the person who is being offered trabeculectomy would most likely during their lifetime. So around the same time as trabeculectomy was first described, another option was described. This is the glaucoma drainage devices. And essentially what these are is instead of creating a hole in the fluid is allowed to percolate back here over a plate. So this gets rid of the issue of having the bleb right here. But there are always issues whenever you put an implant in the eye or anywhere in the body. The implant could move. You put something in the body that's not supposed to be there or not naturally there, there's the risk of infection. Scarring can cause double vision. See, these are the eye muscles here. Put an implant near or underneath the eye muscles, and if they scar the muscle, you can get double vision. It's kind of interesting, actually. The original attempts at this were called setons. And the first setons were actually horsehairs. So it implanted a horsehair here and let the fluid percolate around the horsehair underneath the surface of the eye. It didn't work so well. They finally figured out you actually had to have a tube, not just a seton. Okay. Now, both trabeculectomy and tubes generally work very well at decreasing the intraocular pressure. But because they're relatively high risk, there's been a lot of research, a lot of money going into technologies and procedures to lower pressure without the risk as glaucoma drainage devices and trabeculectomy. This is a procedure that was actually developed by some local ophthalmologist, Dr. Barbelt, who actually developed one of the implants, the Barbelt implant. Despite having developed an implant, he knew there needed to be a better way. So what he looked at doing was, since this seems to be where the restriction is, the drainage grate, the trabectome meshwork, he said, well, what if we just find a way to cut through this and keep it from scarring down? So he developed this thing called a Trabectome. It's essentially an instrument. It creates a cut here, and it's cut in such a way that it tends not to close back up. So you essentially keep that trabecular meshwork open for fluid then to leave through the natural drainage canals, through the canal schlemm that encircles the eye, and then out through the natural collector channels into the venous blood system. So, like many things in life that sound grand, the results aren't always as grand as we hope. Trabectome is something that generally can only be done at the time of cataract surgery because, as you can see here, you're taking an instrument crossing over the lens. Well, anytime you touch the natural lens with something, a cataract develops. So this isn't a procedure that you really want to do when there's still a natural lens. But if you're going to take out the lens, well, it's relatively easy and straightforward to go ahead after the cataract surgery or before and remove some of that tissue. The pressure lowering effect is not as great as glaucoma drainage devices or trabeculectomy, but for somebody who's having cataract surgery and needs pressures in the mid to upper teens, this is a good option. Here's the thing though, not every surgeon has access to the Trabectome. This is a very expensive device. Okay? So in this area, I believe the only access to Trabectome is It's essentially through Doheny, USC. So you need to go through an academic center for that. And my sense is trabectome is starting to fall out of favor for some of the other newer options. Now here, this is EndoCycloPhotocoagulation. This is also one of those surgeries that you can only have at the time of cataract surgery. And the reason for that is you're taking a probe and you're placing it underneath the iris. And what you're doing is you're essentially frying these little, what are called the ciliary processes. This is where fluid is produced. So there's a couple of ways that you can address glaucoma. You can either decrease the fluid produced, or you can help the fluid that's produced get out of the eye. So in the case of drainage devices, trabeculectomy, trabectome, you're helping the fluid get out of the eye. EndoCycloPhotocoagulation decreases the production of fluid, so it's like turning down the tap. The problem is, it's really hard to titrate. How many of these little guys do you have to fry? And nobody really knows. So sometimes you get a wonderful effect, sometimes you don't get much of an effect at all, and sometimes you get too much of an effect. And just as having too much pressure can be bad for you, having too little pressure can be even worse. Because the lens sits right here, and you don't want to nudge the natural lens. Again, you have to first take the natural lens out and put a man-made lens here. So one of the newest procedures to come out, which initially had a lot of excitement associated with it, is called the eye stent. What the eye stent does is it's a little snorkel. It's made of titanium, and essentially you take this and you plug it through the trabecular meshwork into the collector channel. So now you've created this tiny little hole to allow fluid into the collector channel to get out. So this is wonderful. Finally, we found a way to bypass the trabecular meshwork, the point of restriction, allowing fluid into the natural drainage canal, right? So what Carnes was essentially trying to do. A couple of problems with this. One is, this is a really teeny tiny hole right here, and it doesn't get a lot of fluid in there, and it doesn't get a lot of effect. So if you have this surgery at the time of cataract surgery, and this is another one of those surgeries that's safest with cataract surgery, you're going to get a pressure lowering from cataract surgery alone. Right? So about 50% of people with cataract surgery alone, year after surgery, had a satisfactory lowering. About 70% had a satisfactory lowering with the eye stent. So about 20% more, not a huge difference. And here's the thing, 2 years after this was placed, the effect completely washed out. Right? So you say, well, you're there already, you're having cataract surgery, this is the low-risk procedure, why not? I'll tell you why not. This little device is $1,000. Okay? And the Medicare reimbursement for putting one of these things in is $1,000. That's the same amount the Medicare reimburses for surgeries that work a whole lot better, pretty much every other glaucoma surgery out there. So it's pretty easy to see that $2,000 for this is not a very good value. So I doubt that Medicare is going to continue to pay for this procedure much longer once all of the results start coming out. In Canada, they're putting in 2-3 of these things at a time, and that's great if you've got an extra couple of $1,000s to get an extra couple of points of pressure lowering. So now I'm going to cover canaloplasty, which I believe brings us full circle. Okay? Dr. Carnes, back in 1968, wanted to reestablish the natural flow of the eye. Canaloplasty essentially does that. It's minimally invasive. It uses the world's smallest microcatheter. This catheter is 250 micrometers. That's 1/4 millimeter in diameter. It's amazing technology. And what it essentially involves is passing this through the natural drainage canal, called Schlemm's canal, just like you would pass a catheter through vessels in your heart. This is essentially angioplasty of the eye. So let's go ahead and take a look at this video here. Right, so once again, here's the fluid being produced, and it's getting stuck right here. It can't get out this trabecular meshwork. So what canaloplasty does is, just as Dr. Kleins wanted to do way back in the day, a flap is created. But a catheter is placed, which goes all the way around the natural drainage canal. Comes out the other end. And so there's the canal right there. And the whole point is to reduce the pressure. All right, so I'm just going to go ahead and keep talking. And then the neat thing is this. The catheter is pulled back, and as it's pulled back, a viscoelastic gel, so it's a special gel, is injected through the catheter. So just like with angioplasty, a balloon is used. Well, instead of using a balloon, we use a gel to open up the canal. And then just like angioplasty with a stent placed, with that catheter, we can pull a suture back through that canal, tie it off, and tighten it, just like you would a hoodie, right? So it pulls in on the canal, opening it up. And by opening up the canal, you've now reestablished the natural drainage system. So what are the benefits of canaloplasty? It's non-penetrating, first of all. You're not actually creating a hole in the eye, so it's not a full thickness procedure. Right? There's no hole, so there's no bleb. So the risks of the bleb are not there. It lowers the pressure as well as a glaucoma drainage device or trabeculectomy without mitomycin C. So mitomycin C is one of the common antimetabolites that I spoke about earlier that keeps the body from scarring down. If you use mitomycin C, your pressure will be a little bit lower with trabeculectomy, but you're also that lower pressure is going to be bought with higher risk. Just like everything else in life, there's a price. No risk with no reward without risk. It is safer than the traditional glaucoma surgeries of trabeculectomy and glaucoma drainage devices. Those are the features, but these are the real benefits. For people who have a proactive lifestyle, this procedure is really beneficial for them. I've had patients come to me who are ranchers, farmers. I have someone who raises llamas. I have a patient who has flown down from San Francisco. He's a big wave surfer. All of these people were told that they needed trabeculectomy. All of these people were told that they would have to stop doing what they love. And all of these people said, I'd rather go blind. So this is really the first serious glaucoma surgery available for those who really want to continue pursuing their lifestyles and not have their disease take over what they enjoy doing, such as water sports and outdoor activities. So I'm saying that it works well, but what do the studies say? Well, if we look at the studies here, 1 year out, and we've got 3-year results, but looking at just the 1-year results here, you can see that canaloplasty and trabeculectomy, the trabeculectomy with mitomycin C does get the pressure a little bit lower, okay? So here we've got a millimeter of mercury difference. But what did you have to pay to get that millimeter of mercury difference? Up to 20% hypotony maculopathy with likely vision loss. Okay, less than 1% with canaloplasty, up to 20% with trabeculectomy with mitomycin C. Irritation from a bleb? No, canaloplasty there shouldn't be a bleb. You can have irritation from a bleb for life. Not everybody does, but it is possible. Bleb leak, up to 4% per year, with eye infection as a potential, and that potential never goes away. As long as you've got a bleb, you've got the risk of infection. You need to be very careful to have good hygiene if you've got a trabeculectomy. Cataract formation. Minimal risk of that with canaloplasty. And if you do need a cataract surgery after canaloplasty, you get cataract surgery, your pressure drops another couple of points in general. With trabeculectomy, 78% of those who had trabeculectomy ended up with cataracts in 5 years. Okay? One very famous glaucoma surgeon said, looking back at the literature, people who have trabeculectomy are more likely in 5 years to have cataract than they are to have their pressures controlled. So, oh, and by the way, if you've had cataract surgery and you've had a trabeculectomy, the trabeculectomy is more likely to fail. So it's really a no-win situation with cataracts and trabeculectomy. And what about lifestyle issues? Able to enjoy water sports, able to wear soft contact lenses, able to work on a ranch? Yes with canaloplasty, no with trabeculectomy. These are the 3-year results. I showed you the one. Does the pressure lowering stay? And in general, it does. Look how, in the case of canaloplasty only here, in this study, everything was very stable, 16, 16, 16, 15. If we combine it with cataract surgery, it works even better, 12, 13, 13, 13. So, Dr. Robert Stegman, he's the one who, we don't really use the term independent, he's the one who figured out how to do this. He had a population in South Africa. What he says he's just a bush doctor. That's how he describes himself. And his patients were really not ideal patients for trabeculectomy because, one, they were of African descent. They were likely to fail trabeculectomy. 2, he'd see them a couple of times and then he might not see them for another 5 years because they were sometimes hundreds of miles away and it wasn't easy to get in to see him. He developed this surgery specifically to be a surgery that you could, basically do it and forget about it. And he continues to work on this. He's got some really exciting additional things that are not available yet here in the US that can be added to canaloplasty. But I think that this quote is really gets to the core of the issue. It is vital to find a safer, more predictable operation with preferably no complications at all. This is the closest I had ever come to that. And that's Dr. Robert Stegman. Thank you.